and Children with Medical Complexity ECHO. My name is Amy Shaw, and I'm going to be leading today's call. We're so pleased you could join us today. We hope that this virtual community is a place for you to learn, to lean on for guidance and support. During each interactive ECHO session, we will hear from experts as well as offer opportunities to discuss your challenges and experiences around COVID-19 and children with medical complexity. This program is brought to you by the AAP in partnership with the Collaborative Improvement and Innovation Network for Children and Medical Complexity at the Center for Innovation in Social Work and Health based at the Boston University School of Social Work and is funded with support from HRSA. This program does not necessarily reflect the official views of the AAP, Boston University, HRSA, or HHS. Just a few housekeeping items. This ECHO session will be recorded for education and quality improvement purposes. Slides from today's call, along with a video recording of the lecture, will be shared following the call today. However, a recording of the case discussion will not be shared, and this is to ensure confidentiality and provide a safe space to discuss concerns and questions. Please ensure that patient privacy is protected and do not provide any PHI during today's call or any of the ECHO sessions. Make sure that your microphone is muted during the session. You will have the ability to unmute and mute yourself to participate in today's call. If you do have any IT related issues, please chat into AAP admin and we'll assist you along the way. If you have video capabilities, please enable it. It makes for a better, for more interactive and engaging session if we can all see each other. Finally, please enter your name and where you're from in the chat box so that we can get to know each other and so that AAP can count your attendance. As you can see over here, we have a wonderful interdisciplinary team of faculty for this program. This team represents expertise in a variety of areas important to the care of children with medical complexity during the COVID-19 pandemic. Our faculty helped to advise the content for this program, and we're extremely grateful for their time and support. We also do invite guest faculty members for particular sessions for a wider breadth of expertise where it's useful. In addition to our faculty members, we do welcome all of you. We know you all have expertise in your various fields, and many of you have firsthand experience with COVID-19. All input is welcome during the ECHO session, and we look forward to hearing from you. For today's session, our topic is on school reentry for children with medical complexity. Our guest speakers are Nathaniel Beers and Stephanie Porter, and thereafter we'll have a case presentation by Brandon Smith. Nathaniel Beers, he's a president of the HSC healthcare system at Children's National Hospital. He previously served as a chief operating officer, chief of specialized instruction, and executive director for early stages in the Office of Special Education in DC Public Schools. Nathaniel sees patients as a general and developmental behavioral pediatrician at Children's National Hospital, where he was the medical director of the Children's Health Center at CMC. Prior to joining DC Public Schools, he was Deputy Director of Policy and Programs for the Community Health Administration of the DC Department of Health and the Title V Director for DC. He served on the Mayor's Advisory Committee on Child Welfare and Child with Special Healthcare Needs Advisory Board. He also serves on the Council of School Health for the AAP. Stephanie Porter is a nursing faculty for the Leadership Education Neurodevelopmental Disabilities and Related Disorders program at the Institute of Community Inclusion at Boston Children's Hospital. Her training extends beyond the hospital walls into the community as a program project coordinator within the Pediatric Medicine Services program at Boston Children's Hospital. Stephanie is nationally known for her work with children supported by medical technology. I'm going to turn it over to Nathaniel Beers for you to continue the lecture. Thank you.
Great, thank you. Neither Stephanie or I have any conflicts, and as we noted, this didactic session is not necessarily the views of the AAP. So we'll move forward with this talk. So next slide. Almost 2 weeks ago now, the AAP released its guidance on school reentry relative to COVID. And so I'm excited to share that with you here today and help you think about sort of how that overlays with children with medical complexity. And so the premise of the statement is that AAP advocates strongly that all policy considerations for the coming school year should start with the goal of having children, students physically present in school. And this bears out because of taking a view of the whole child and the health of the whole child and ensuring that we acknowledge the inequities that have existed during school closures that will continue to exist during virtual learning if we don't figure out ways to get more children in school more frequently for in-person learning. Next slide. So there are several guiding principles that were used to sort of think through this guidance. First is that we must acknowledge that these policies, as schools are developing them, need to be flexible and nimble because the information continues to change, even since last week. There have been movement in some of the areas around our understanding and the conversations going on relative to the way the disease is spread. And so certainly we need to continue to react to those. Schools need to develop strategies that can be revised and adapted to the level of viral transmission in the school and in the community. This is to acknowledge the fact that what may work in one school district, which has very low viral transmission in the community, is going to be very different from school communities that are experiencing high levels of community transmission right now. These policies need to be practical, feasible, and appropriate for the student's developmental stage as well. In addition, there need to be special considerations and accommodations to acknowledge the diversity of youth that are in schools, including vulnerable populations, the medically fragile, like we will talk about today, those in poverty, those with developmental challenges, certainly special healthcare needs and disabilities, all are relevant to making sure that we can return to school. Next slide. In addition, we need to make sure that no child or adolescent is excluded from school unless required to adhere to public health orders. That is to make sure that children with medical complexity are not just excluded out of hand, but rather there are individual conversations that are part of pediatricians, families, and schools partnering together to make sure that we are collaboratively identifying and developing accommodations that are needed in order to allow children to attend school safely. School policies also need to be guided by supporting the overall health and well-being of all children, adolescents, their families, and communities. And as I noted earlier, certainly we've seen inequities around nutrition and access to food that is not equitably available to all kids who are out of school, as well as all of the healthcare services that children receive in school, and as well as behavioral health support, social emotional development, and special education services. Next slide. So we're going to talk about a couple different areas, physical distancing being the first. The CDC guidance has been that we should be maintaining 6 feet distance between desk and kids when feasible, the key being when feasible. If schools are going to maintain 6 feet, it means that almost every school is going to have less than 50% of their children in the building at any given time. There is evidence that came out of Lancet and on June 1st that suggests that 6 feet distance may not be any better than 3 feet, particularly if you're using cloth face coverings, but should be contemplated as part of the conversation as we move forward. It is, however, very important that we encourage adults to maintain social distance. There is increasing evidence that there is a higher degree of spread between adults than from children to adults. And particularly if you think about sort of how teachers and schools may be set up, you may have teachers who are very good about social distancing in the classroom and need some downtime, and in the teacher's lounge are more likely to be closer together. And the data out of Australia suggests that teachers actually get COVID more likely from the teacher's lounge than they do from the classroom itself. There's some grade-specific issues that need to be addressed. Certainly social distancing or physical distancing for pre-K and preschool is going to be much harder to do, and thereby thinking about how you're reducing spread needs to include thinking about cohorting of groups to make sure that there's decreased crossover. On the elementary side, certainly thinking about spacing of desks as well as cohorting will be important. On the secondary side, knowing that students are often changing classes, spacing of desk is important. Contemplating minimizing or eliminating lockers as high touch areas will be an important part of developing plans, as well as increased spacing if activities that increase exhalation, such as singing or exercise, are going to happen. Next slide. Certainly, there are some special circumstances. Busing should be taken into account. Sort of both the physical distancing and the face coverings should be contemplated as part of busing. Thinking of assigned seats and other components. If there's specific busing issues, there's a number of additional recommendations in the statement itself. Hallways, the goal is really to minimize, reduce traffic in hallways, and also think about strategies that are going to change flow patterns to reduce contact between students and staff during transitions that need to happen. Clearly, we want to make sure that kids have adequate nutrition, and so making sure that meals are being provided, but reimagining sort of where students eat, either in classrooms or other spaces, to think about how they can do that. Certainly, outdoor spaces are going to be better than indoor spaces, but that may not be an option in all areas of the country or in all school buildings based on the way that they're structured. Playgrounds is another hot topic, and certainly enforcing physical distancing outdoors is going to be near impossible to do. And so thinking about strategies to effectively reduce risk. So thinking about group sizing, thinking about cohorting, and making sure that if playgrounds are being used in schools, that they are part of the cleaning plan that schools are setting up. Next slide. Face coverings clearly have become a political hot topic. The AAP has put forward these guidance based on what the science is and what the recommendations are currently. And so cloth face coverings should be used as possible based on developmental capacity as well as feasibility. And you'll see a little bit of that when we talk about the grade specific issues. It is going to be critical that staff wear face coverings, particularly if they're closer than 6 feet with students or staff. And there do need to be some special considerations, particularly for early childhood, as well as English language learners and special education classes, where the face covering may impede the ability of that student to effectively learn language. And so clear masks or masks unmasking for specific times during the day may be appropriate. Masking and protective equipment for medical procedures should be based on the current CDC recommendations, and they are clearly getting updated regularly with new updates about aerosolized generating procedures even in the last week. On the grade specific side of things, clearly pre-K and preschool may be difficult to implement and be irrational to really fight with students all day long about if you're going to have difficulty in implementing them. On the elementary school side, certainly face coverings should be encouraged. However, there may be some developmentally appropriate accommodations made, acknowledging that younger students may be pulling the mask down, touching their nose and mouth all day long, and that the benefit of the mask may be lost if that is what is occurring. And yet there are students who are as young as 6 who are capable of doing it. And last week we had a very robust conversation about encouraging patients, families to start practicing now so that that transition into school will be easier for younger kids as well as those with developmental issues. On the secondary side, we are recommending universal use of cloth face coverings for middle and high school students, particularly when they're not able to adhere to the social distancing recommendations. Next slide. On the cleaning and disinfecting side of things, clearly continuing to frequently hand wash, making sure that high touch areas are getting cleaned as much as possible and at least daily. But also thinking about things, if you can leave classroom doors open so that people are not touching the doorknobs all day long, clearly those will be helpful. And as I said earlier, making sure that outdoor spaces are included in the cleaning plans, particularly railings in and out of schools, but also playground equipment as recommended. Next slide. Screening and testing continues to be a hot topic. I know that the AAP is working on some new testing recommendations that should be coming out in the next couple of weeks. And so hopefully that will help provide some additional information for pediatricians and school health individuals. But part of what we talked about in this guidance is recognizing that temperature and symptom screening may not be feasible in person, certainly even if you have 50% of your students, if you have 500 to 1,000 kids in your classroom or school, even if only 50% of them are coming, that would take hours in order to get through that type of screening process. And so schools need to contemplate whether or not they're going to do reporting from parents as part of that process. Clearly, the messaging from us as pediatricians, from school officials needs to be that people should be staying home if they are sick. and connecting with their primary care providers as part of that process. Testing prior to school entry is not going to be very valuable and is likely to give schools a false sense of security. And clearly there are limitations to testing capacity in many communities that would make it near impossible to do enough regular testing to have it be viable to really help manage the population. Clearly, staff and students should be encouraged to connect with their medical providers if they need testing because they have symptoms. Next slide. On the mental health side, clearly, this has been a huge strain and stress on families and students. We need to recognize that students, when they show up on day one, may not be ready to learn, and that schools need to be prepared to address the increased anxiety in the students and the families, the decreased attention span due to additional time that they've been spending virtually, online, in front of screens, but also the decreased educational time that they've had, as well as recognizing that many of the kids are going to have experienced stress and trauma while they have been out of school, and that trauma needs to be something that schools are prepared to address as they come back to school. But beyond just the students, we also need to acknowledge that this has been an incredibly stressful time for the staff in schools as well. And we need to make sure that they are getting the support that they need from schools and school districts and local governments to make sure that they can actually be ready to teach and support students who they're being asked to support. Next slide. So what about medical complexity, and how do we address the issues around children with medical complexity? Clearly, we need to be planning today, tomorrow, every single day that we have before school opens. This means connecting with patients, families, the medical team, as well as the school team, and creating an ongoing dialogue, because this is going to shift. As I said earlier, these plans need to be nimble, they need to be flexible, they need to acknowledge that the disease burden is going to look different tomorrow than it did today, and we need to be prepared to address those. Those plans need to be based on the current information that is available and make changes as needed. Clearly, there will need to be work around development of IEPs and review of those IEPs and adjustments to those IEPs, as well as individualized health plans to make sure that they can be effectively implemented and that the students are getting the support that they need. And remembering that the goal is to work together to reduce risk, not eliminate that risk. Opening schools is inherently going to have risk involved, and our goal together is to make sure that we are reducing that risk, helping families make the determination as to what they need in order to make a good decision for them and their family about return to school. And I'm going to turn it over to Stephanie now.
Thank you for inviting me today to present on this timely topic. So most of my presentation today will be based on work that I have done with Project School Care with Dr. Judy Palfrey, and currently with the MassDOT program that's supported by DPH Title V program to support the educational entrance process of children with special healthcare needs who are assisted by medical technology. So what do we know from the past? We know that communication and collaboration is essential. We need to be talking to all providers. We need to be making sure that parents are at the table, and that we know that school nurses have been essential in planning that occurs in the school setting. As Jonathan mentioned, we need to plan. Early planning works the best. We need to identify the healthcare needs of the child. We need to look at the environment. We need to look at what kind of services that the child needs at home. What have we learned about IEP and 504s? Well, we know that identifying the healthcare needs of the child and putting those accommodations in both the IEP or the 504 is what is helpful. Health and education staff need to work together to make this happen for kids. We know that training is essential for school teams. In the past, we've done trainings on infection control, technology, how to do trach care. And we know that going forward, we'll probably need to do more training. And we do know that schools appreciate support and guidance and recommendations. And in the past, Dr. Palfrey and I and others have created a guideline for schools regarding children with special healthcare needs that outlines emergency action plans, how to take care of kids with trachs and vents and G-tubes and diabetes and all of that. So we know that helps. Next slide, please. So how do we think about the kids from who have different situations? So just thinking about a first school experience for a 5-year-old who has a trach and is on a vent. What do we need to think about? Her suctioning needs. We need to think about, is there a separate place for that child? Are the 3-year-old with cystic fibrosis, are there specific needs that this child will need? Are the newly diagnosed 10-year-old with diabetes who is going to be involved with going to the school nurse many times a day? Or the 17-year-old with ventricular assisted device and heart transplant, or a 5-year-old with cochlear implant who may not be able to read through a mask, see through a mask, even if it's a clear mask, or a 13-year-old with common variable immune deficiency that I just learned about this week, who has aid changes in the school setting. How will we accommodate for that child? Next slide, please. What about the kids with medical technology? We know that the issue of aerosolized particles is really the top technology issue right now. We know that kids with trachs and vents and nebulizers, there's a lot of talk going on about how we can do that care for that child. We know that with kids with suctioning, we can do inline suctioning. We know with nebs, we might be able to switch over to an MDI. But will the providers need to wear N95s? If we model ourselves after the outpatient clinics, right now the nurses and docs are wearing N95s. They're using separate rooms. They're waiting 30 to 60 minutes between any child going in. So do we need to look at that? We want to minimize the disruptions for each of these children by making sure that everyone gets their procedures, but also gets their education. Next slide, please. So we know we're getting a lot of guidance from a number of different places, boards of education, CDC, AAP. I know National Association of School Nurses are coming out with some guidance. And then local schools need to submit. So we may see in any one given state or any one given town that different schools are offering different suggestions for how they're going to have a process for kids with special healthcare needs. Families are looking at the risk benefit. We know there are 3 models being offered, a hybrid, a remote, and a home model. So when we're planning, we need to be thinking about how we can incorporate all of that care into the healthcare plan and into the educational plan as well. Jonathan mentioned transportation. I know companies are looking at how can we actually sit several people in a van at the same time, along with maybe a nurse that might be a one-to-one nurse. Social isolation, families are very concerned that this may mean less integration at school. And we know that families are feeling very traumatized. Some families have said they have mental congestion and stress beyond anything that they've felt in their lifetime. But others are saying that the kids have been very resilient, which is nice to hear. Next slide, please. In terms of the environment, we really need to be looking at the air quality. We need to be talking with our infection control experts about transmission. We need to think about the siblings. I have one family right now that has a child with congenital neutropenia, and she has a very good system of care with the siblings right now that the school nurses will tell her if there's anything contagious in the school. So this is very different for her now because she's thinking with the information from what she's getting from her specialist that this child will stay home this coming year. But what will happen with the siblings? How will we accommodate for the siblings? Use of PPE is huge. I have another youngster this week who gets suctioned every 20 minutes. And how will a nurse don and doff each time and the amount of time that that's going to take, and how can we set up a room, another separate room for that child? A lot of families are concerned about compensatory services. Will they get compensatory services for what their children have missed? And a lot of kids have missed a lot of services. A lot of the summer programs are being done remotely, and I'm still hearing that a lot of our kids do not have the equipment that they need. So we need to make sure that anything that's coming up in the future, that we make sure we put it in the IEPs. Next slide, please. We need to be thinking about how the services are delivered. If kids are getting services at home, families are concerned with many nurses coming in their homes. Let me rephrase that. Families are concerned that many professionals will be coming in their homes, and they want to keep the interaction as as the least amount of interaction as possible. So we really need to be thinking of that as well. Next slide, please. So we need to look for the helpers, and you will always find people who are helping. Fred Rogers was a master at thinking about things like this. Next slide. So the most important thing I think right now is, how do we take all of the guidance that we have learned and put it into some action steps? We know we need to have parents and school nurses at the table. We need to make sure that families have the evidence that's related to transmission. We need to give guidance related to certain populations. We need to help schools with education around trauma-informed care. Right now, we're thinking about doing, in another program I work with, we're thinking about doing some education for the school nurses. We need to make sure that everything is incorporated in the IEP and the 504 to apply to all models, the hybrid, the school, and the home model. And now it's your turn to think about asking questions, and then we'll do a specific case. Thank you.